Welcome to the deep dive. We're here to help you cut through the noise, bypass that information overload.
Right.
We dig into the sources, pull out the key insights, the surprising facts, so you get informed without drowning in data. Today, let's unpack this. We're diving into something really crucial, but often super confusing in federal workers' comp.
Which is?
The OWCP Schedule Award.
Yes. It's fascinating how these awards are set up to compensate for those lasting impacts from an injury.
Exactly.
So our mission today really is to just demystify what a schedule award actually is, how it's calculated, and this is key, using a very specific standard, the AMA Guide's 6th edition.
The 6th edition, got it.
And, probably most importantly, why getting an expert rating is so vital for federal employees.
Okay, and to do this, we've got some great sources lined up. We're drawing from OWCP Schedule Awards by body part with 6th edition examples, which pulls together official DOL stuff, Federal Disability Resources.
The official guidelines.
Academic research, and also insights straight from Dr. Kendra Pearson's clinics.
You're a real expert in the field.
Definitely. So, look, whether you're a federal employee yourself, maybe you know someone who is, or honestly, if you just find complex systems interesting.
Which this definitely is.
Oh, yeah. Get ready for some aha moments about a benefit that could seriously impact someone's future.
Let's dive in.
All right, let's start right at the beginning. The basics.
Yeah.
What is an OWCP Schedule Award, fundamentally?
Okay, think of it like this. It's a specific, usually a one-time payment.
One time, okay.
For a permanent impairment. Or, the lasting loss of use of certain body parts after a work injury.
There's parts, not everything.
Not everything, we'll get to that. And it's paid after you hit what's called maximum medical improvement, MMI.
MMI, right.
Which just means, basically, your condition has stabilized. It's not really expected to get significantly better with more treatment.
So the damage is essentially done.
It's compensation for that lasting damage, exactly, the permanent change.
Okay, so you've got an accepted OWCP claim. You've reached MMI. What are the next steps? What determines the award?
So the law itself, FECA, assigns a fixed number of weeks of compensation for a 100%, a total loss of use for specific body parts. It's like a schedule, hence the name.
Makes sense. Can you do some examples?
Sure. So for a complete loss of an arm, the schedule assigns 312 weeks.
312.
A leg gets 288 weeks. A hand, 244 weeks.
Okay.
A foot is 205 weeks, and an eye is 160 weeks. And of course, most impairments aren't 100%.
Right, they're partial.
Partial losses are just compensated proportionally based on the percentage of impairment.
That schedule seems pretty clear, but you mentioned certain body parts. What about injuries to parts that aren't on that specific list? Like the back. That's a common one.
That's a really excellent question and a point of confusion for many. So while lots of body parts are scheduled, arms, legs, hands, feet, eyes, hearing, fingers, toes, the spine or the back itself isn't explicitly listed for a direct schedule award.
Okay, so no award for just a bad back.
Not directly for the back structure, but, and this is a critical nuance, if that spine injury causes a measurable permanent impairment in a scheduled body part. Like, say, nerve damage from a herniated disc that leads to permanent weakness or numbness in your leg or foot.
Right.
Then the impairment to the leg or foot can absolutely be rated and awarded under the schedule.
So it's an indirect path based on the consequences.
Exactly. Even if your primary injury site isn't scheduled, its effect on a scheduled limb might be. Very important distinction.
That really is critical. Okay, so let's say an impairment percentage is determined for a scheduled body part, directly or indirectly. How does that translate into, actual money?
It's actually a pretty straightforward formula once you have that percentage.
Okay.
The schedule award amount equals your OWCP compensation rate.
Right.
Multiplied by the total number of weeks assigned to that body part for a 100% loss.
Like the 312 for the arm.
Exactly. And then you multiply that by your specific percentage of impairment.
Got it. And the compensation rate, what determines that? Is it based on salary?
Yes, it's based on your average weekly wage at the time of injury. Typically, the rate is 66 and 23% of that wage.
2/3.
But if you have dependents, a spouse, children, it increases to 75%.
Okay, 75% with dependents.
Yeah.
So the government is essentially calculating a set number of weeks of your historical income level as compensation.
That's a good way to put it. Compensation for the permanent physical change based on your earning capacity at the time.
Okay, let me try to walk through this.
Right.
Let's say someone has a 10% impairment of their hand.
Okay.
And the hand is assigned 244 weeks for a total loss.
Right.
So 10% of 244 weeks is 24.4 weeks of compensation.
Correct.
Now, if their weekly comp rate, let's say it's $600, then 24.4 weeks times $600 a week. That comes out to $14,640.
Exactly. That would be the schedule award amount.
And here's what I find really, really interesting about this. You're saying these awards compensate for the permanent loss of function.
Yes.
Completely independent of any wage loss benefits someone might be getting or might have gotten.
Absolutely independent.
So somebody could potentially be back working their full job, earning their full salary,
Yep.
and still be eligible for potentially tens of thousands of dollars for a permanent impairment from an old injury.
That is absolutely correct. And it's a point many people, even claimants sometimes, miss.
That really shifts the whole perspective on workers' comp, doesn't it? It's not just about lost paychecks.
Precisely. It's not about your ability to work now. It's about the lasting physical deficit, the change to your body that's quantifiable using the guides, regardless of your current job status. It's a benefit for the permanent physical loss itself.
Wow. Okay. Now, you mentioned the guide several times. Let's talk about the absolute foundation for getting these ratings. The AMA Guides to the Evaluation of Permanent Impairment, 6th edition. Why is this specific book, this edition, so incredibly important?
It's non-negotiable. It's a strict, hard rule from OWCP. All impairment ratings submitted for schedule award consideration must be done using the 6th edition. Full stop.
Not the 5th, not the 4th, only the 6th.
Only the 6th. If a physician uses a different edition, or if the report isn't clear, isn't defendable under the 6th edition's rules, OWCP will simply reject it.
What happens then?
Well, your claims examiner isn't usually a medical expert, right? They send the report to OWCP's own medical experts, the district medical advisors, or DMAs.
Okay, the DMAs. They're the gatekeepers.
They really are. They review the rating report. If they spot any deviation from the 6th edition, if the methodology isn't right, if the math is wrong, if it's based on the wrong edition, they can send it back demanding clarification, or they might just flat out deny a rating.
Which means the employee potentially gets nothing.
Potentially 0 award, yes, or a significantly lower award than they might be entitled to. Using the correct edition and applying it correctly is paramount.
Okay, so this 6th edition, how does it actually work? How does it guide a doctor to arrive at, say, that 10% hand impairment number?
It's fundamentally what's called a diagnosis-based methodology, DBI.
Diagnosis-based.
Yeah. So the physician starts with your specific confirmed diagnosis, like, say, a rotator cuff tear that was surgically repaired, or carpal tunnel syndrome.
Okay.
They find the corresponding chapter and table or grid in the guides for that condition. That grid provides a default or a starting range for the impairment percentage based purely on the diagnosis itself.
So it's standardized from the start.
Very standardized. It's meant to be an evidence-based approach, linking specific conditions to impairment values.
But it's not just the diagnosis, right? People recover differently.
Exactly. That diagnosis gives you the starting point or range. Then the doctor has to refine that rating.
Refine how?
By considering key clinical information. Things like your functional history, how does the impairment actually affect your daily activities? Specific findings from the physical examination, like measured weakness or loss of motion, and results from clinical tests, maybe nerve conduction studies or imaging results.
Okay.
These factors, according to specific rules in the guides, can adjust the impairment percentage up or down within the range allowed for that diagnosis. The goal is consistency.
Consistency, maybe.
Meaning, in theory, two different doctors, if they're both properly trained in the 6th edition and have the same clinical information, should arrive at very similar, if not identical, ratings for the same condition.
Applying the rules correctly, you said. Are there common pitfalls, complexities that maybe a doctor who doesn't specialize in this might miss?
Oh, absolutely. The guides are complex. For instance, take upper extremities, arms, hands.
Okay.
Diagnosis-based impairment, DBI, is usually the primary method. But for some conditions, the diagnosis grid might also allow for using a range of motion, ROM, measurement method.
So, two possible ways to rate the same arm.
Potentially, yes. And the guides explicitly state that in such cases, the physician should calculate the impairment using both methods, if applicable.
Okay.
And then use whichever method yields the higher rating for the final impairment score.
Higher rating. Interesting. So you don't just pick one.
You're supposed to choose the one that benefits the claimant the most, provided both are applicable under the rules. Missing that single instruction could mean a significantly lower rating.
Wow. That really underscores the need for a physician who is not just familiar with, but truly expert in the 6th edition, doesn't it?
Absolutely. An incorrect application, even an unintentional one, could literally cost an injured worker thousands or even tens of thousands in benefits they are legally entitled to.
Okay, we've covered the rules, the formulas, the importance of the 6th edition. Let's make this more concrete. Can we walk through a few examples, like fictional scenarios based on real cases showing how this plays out?
Yeah, definitely. Real-world context helps illustrate these principles. Let's start with, say, John.
Okay, John. Tell us about him.
All right, imagine John. He's 45, works as a USPS letter carrier in Kansas City. Tough job, physically demanding.
Sure is.
One day, lifting heavy mail bags, he feels a tear in his left shoulder. Diagnosis: full-thickness rotator cuff tear. Needs surgery.
Ouch. Common injury for that kind of work.
Very. So he has the surgery, goes through months of physical therapy, and eventually his doctor says he's reached maximum medical improvement, MMI.
Yeah.
But, even after all that, he's still got some residual weakness in the shoulder, some pain, especially when lifting or reaching overhead. It impacts his job.
Right. It's not 100% back to normal.
Exactly. So for John, a physician certified in the 6th edition would evaluate him. They'd use the shoulder regional grid in the AMA guides.
Okay.
Based on his diagnosis, rotator cuff tear, the fact he had surgery, and his moderate residual problems, weakness, pain with activity, the guides might place him around, say, 13% impairment of the arm. In this specific scenario we're using, based on clinical examples, let's say Dr. Pearson, applying the guides meticulously, assigned him 10% permanent impairment of the left arm.
Okay, 10% of the arm. Now remind us, what's the total week value for an arm?
312 weeks for 100% loss.
So John's 10% impairment gets him 10% of 312 weeks. That's 31.2 weeks of compensation.
Correct.
And if his weekly comp rate is, let's say, $800, 31.2 weeks times $800, that's just under $25,000, $24,960.
Exactly. And this really highlights that key point. Even after a successful surgery, a measurable permanent impairment often remains.
Yeah.
And the 6th edition provides the framework to quantify that impairment consistently, ensuring John gets the award he's due for that lasting change.
Okay, great example. Let's take another one. How about Jane?
All right, Jane. She's a transportation security officer, a TSO working in St. Louis.
Okay, PSO. Lots of standing, walking.
Definitely. She injures her right knee in a fall at work, tears her ACL, that's a major ligament, and also her meniscus, the cartilage cushion. Requires reconstructive surgery.
Nasty knee injury.
Yes. And despite the surgery and rehab, over time, she develops significant post-traumatic arthritis in that knee joint. Makes standing for long shifts very painful. She reaches MMI.
So more complex than just a simple tear.
Much more complex. A simple meniscus tear without ligament damage might only rate, say, 2–5% impairment of the leg under the 6th edition.
Okay.
But Jane has the ACL reconstruction plus moderate arthritis. Both contribute to her impairment. So combining these factors using the knee regional grid and arthritis rules in the guides, Dr. Pearson might find her impairment to be, let's say, 25% of the right lower extremity.
25% of the leg? That sounds significant. What's the week value for a leg?
288 weeks for 100% loss.
Okay, so Jane's 25% impairment translates to 25% of 288 weeks. That's 72 weeks of compensation.
Right, 72 weeks.
Now, let's say Jane has a dependent. So if her comp rate is 75% of his salary, if her average weekly wage was $1,000.
Her comp rate would be $750 per week.
So 72 weeks times $750 a week. Wow, that's $54,000.
A substantial schedule award, yes. And it reflects the severity. Jane's case shows how multiple related conditions in the same limb, the ligament damage, the resulting arthritis, are combined under the 6th edition to arrive at a total impairment rating.
And every percentage point matters financially.
Absolutely. Each point translates directly into more weeks of compensation.
Let's do another one. How about Mark? Wrist injury.
Okay, Mark. He's a nurse at a VA hospital. His job involves a lot of repetitive tasks, typing patient notes, handling medical instruments, maybe assisting patients.
Right, lots of hand and wrist use.
Yeah, exactly. He develops carpal tunnel syndrome in his right wrist, fairly common repetitive strain injury.
Understood.
He undergoes carpal tunnel release surgery. It helps, but afterwards he still has some ongoing numbness in his fingers, though his grip strength has improved. He reaches MMI with these residual symptoms.
So again, improvement, but not a complete fix.
Correct. Now, for Mark, the 6th edition has specific sections for rating entrapment neuropathies like carpal tunnel. It's based primarily on the level of nerve dysfunction, sensory loss, motor loss.
Okay.
So considering Mark's ongoing numbness, sensory deficit, but improved strength, less motor deficit, his condition post-surgery might be classified as, say, a mild residual median nerve impairment.
And what percentage would that translate to?
Using the specific tables for the median nerve in the guides, Dr. Pearson might calculate this as a 5% permanent impairment of the hand.
5% of the hand.
Okay.
And the hand's value.
244 weeks for 100%.
So Mark's 5% impairment gets him 5% of 244. That's 12.2 weeks of compensation.
Correct.
If his weekly comp rate is, say, $900.
Then 12.2 weeks times $900 is about $11,000, $10,980.
Okay, so a smaller award than Jane's, but still significant.
Absolutely. It recognizes that even a mild residual impairment, that lasting loss in dexterity or sensation, deserves compensation. And what's interesting here is the specific methodology.
How so?
The 6th edition rules for nerve injuries involve grading sensory and motor deficits on specific scales. A doctor really needs to know these specific tables and rules to arrive at the correct, highest defensible rating. Even a few percentage points difference matters.
Right. Precision is key.
Yeah.
Okay, one more example. Let's talk about Lisa and that back injury scenario we touched on earlier.
Perfect. Lisa. She works for the Department of Defense, maybe a desk job, maybe something more active. She suffers a lower back injury at work, herniated disc.
Okay.
She undergoes back surgery, but unfortunately it results in permanent nerve damage. Specifically, she develops weakness and numbness down her left leg and into her foot. It's a condition sometimes called drop foot, making it hard to lift the front part of her foot when walking. She reaches MMI.
So the primary injury was the back, but the lasting impairment is in her leg and foot.
Precisely. And this loops back to our earlier discussion. There's no direct schedule award for the spine itself under OWCP rules. However, because Lisa's work-related back injury caused a measurable permanent impairment in her legs specifically due to damage to the L5 nerve root coming from her lower back.
Which affects the leg muscles and sensation?
Exactly. She can receive a schedule award for that affected leg impairment.
Okay, so how is that rated? Is it complicated?
There are specific OWCP guidelines and 6th edition chapters for rating spinal nerve impairments that affect the extremities. An expert physician following these rules might determine that the L5 nerve root damage results in, say, a 10% permanent impairment of Lisa's left lower extremity.
10% of the leg. And the leg's full value is 288 weeks.
Correct. So 10% of 288 weeks is 28.8 weeks of pay.
And if Lisa's comp rate is, say, $800 a week.
That would be 28.8 times $800, which is about $23,040 or $40.
So even though her back wasn't directly scheduled, the nerve damage it caused in her leg resulted in a significant award.
Exactly. Lisa's case is a really key educational point. You always have to ask, did the work injury cause any permanent measurable impairment in a scheduled body part, even indirectly? A physician less experienced with OWCP might just say, oh, it's a back injury, sorry, no schedule award, and completely miss the secondary impairment in the scheduled limb. That's a costly mistake for the employee.
It really seems crystal clear from these examples that getting an accurate impairment rating based strictly on that 6th edition is absolutely the key to maximizing a schedule award.
It truly is. The entire award hinges on that percentage.
So this naturally leads to the question, what kind of specialist, what kind of physician should a federal employee be looking for to make sure this is done right?
You need someone who hasn't just, glanced at the 6th edition, but someone who has really dedicated their practice to mastering it, specifically within the context of federal workers' compensation.
Not just any doctor.
Definitely not. You want someone with a proven track record whose reports are known to be thorough, well-reasoned, and fully compliant with OWCP's requirements. Someone like Dr. Kendra Pearson, for instance.
Tell us more about her specialization.
Well, Dr. Pearson is a prime example. She's a leading specialist, fully certified as a 6th edition impairment rating physician. Her entire practice is essentially devoted to mastering orthopedic impairment ratings using those AMA guides, 6th edition. And she brings over 20 years of orthopedic healthcare experience to the table.
So she lives and breathes this stuff. It's not just a side part of her practice.
Exactly. It's her primary focus.
And you mentioned her approach is thorough. It's not just a quick 15-minute exam then.
Oh, not at all. Her evaluations are comprehensive. She'll do a detailed history, a meticulous physical exam, review all the medical records, and often she includes what's called a functional capacity evaluation, or FCE.
An FCE, what does that measure?
It's a series of standardized tests designed to objectively measure someone's functional limits. Things like how much they can actually lift, carry, push, pull, their range of motion, endurance, ability to stand, walk, bend.
So objective data to back up the clinical findings.
Precisely. It adds another layer of objective evidence to support the impairment rating. Because she focuses solely on federal workers' comp, she knows exactly what OWCP needs to see. Nothing gets overlooked.
What is it about a specialist like Dr. Pearson, who's so dialed into this specific area, that makes such a difference for federal employees needing these ratings? Why do people seek her out?
I think it boils down to trust and results. Her reputation is built on providing accurate, detailed, and highly defensible ratings.
The defensible meaning OWCP accepts them.
Yes. Her reports are meticulously crafted to be OWCP compliant. They clearly explain the diagnosis, the findings, and, critically, how the 6th edition rules were applied to arrive at the rating percentage. This significantly smooths the path for approval by those OWCP district medical advisors we talked about.
Because many other physicians might not have that level of familiarity.
That's often the case. Many doctors, even excellent clinicians, just aren't deeply familiar with the specific, sometimes quirky requirements of the federal system. They might accidentally use the wrong AMA Guides edition, or not understand the specific rules for combining multiple conditions in one limb, or how to handle pre-existing conditions.
Combining conditions. That came up with Jane's knee. How does OWCP handle that, especially if there was a pre-existing issue?
That's another crucial point where OWCP differs from many systems. If you have multiple accepted work-related conditions affecting the same limb, like Jane's ACL tear and her arthritis, they are combined using specific formulas in the 6th edition to get a total impairment rating for that limb. And importantly, OWCP generally does not apportion for pre-existing conditions in schedule awards.
No apportionment. What does that mean?
It means if you had, say, mild pre-existing arthritis in your knee, and then you suffer a work injury to that same knee that makes the arthritis much worse and adds ligament damage, OWCP typically rates the total current impairment of that knee. They don't try to subtract out the portion that might have been pre-existing.
So they rate the knee as it is now, post-injury.
Generally, yes, for schedule award purposes. This can significantly increase the award compared to state workers' comp systems or other disability programs where apportionment is common.
Wow. That's a huge advantage for the federal employee, but only if the doctor knows the rule.
Exactly. A doctor who understands OWCP rules ensures you get rated for the full extent of your current impairment in that limb, maximizing the schedule award you're legally entitled to. Dr. Pearson essentially speaks OWCP fluently.
And beyond just the technical side, the reports and the rules, what about the patient experience?
From what we understand, Dr. Pearson and her team are really passionate about patient education and advocacy. They take the time to actually explain the injury, the rating process, what it all means in plain language.
That must be reassuring for someone going through this complex process.
Absolutely. Her philosophy seems to be that federal workers dedicate themselves to serving the country, and when they get hurt on the job, they deserve not just expert medical evaluation, but also clear guidance and support navigating the compensation system.
That makes a lot of sense. Okay, so let's bring this all together. What's the big takeaway for our listeners from this deep dive?
I think the main thing is that an OWCP schedule award is a really significant and often overlooked benefit for federal employees who have suffered a permanent impairment from a work injury.
Right, it's compensation specifically for that lasting physical change, and importantly, it's separate from wage loss. You can get it even if you're back at work.
Exactly. And understanding that it's meticulously calculated using one specific standard, the AMA Guides 6th edition helps demystify how that compensation is determined.
Yeah, and we saw through the examples, John's shoulder, Jane's knee, Mark's wrist, Lisa's leg via her back, how different injuries are quantified and how crucial that expert evaluation is.
Absolutely critical. Each case highlighted the nuances and the importance of applying those 6th edition rules correctly.
So if you're a federal employee and you're approaching MMI, or maybe you've passed MMI for a work injury,
Take this knowledge seriously.
don't just assume the schedule award part will take care of itself or that any doctor can do the rating properly.
Definitely not. You really need to seek out a qualified physician who specializes in 6th edition impairment ratings for OWCP. Someone who truly understands the system's intricacies, like Dr. Pearson and her team, to ensure you get the maximum benefit you're entitled to.
Right. Your injury has already cost you enough physically and perhaps emotionally.
Exactly. When it comes to the compensation you deserve for that permanent loss, you want the best possible assessment, backed by the solid, objective methodology of the AMA Guides, interpreted by an expert. Don't leave money on the table due to an incorrect or incomplete rating.
Well said. And that leads us perfectly into our final provocative thought for you as a listener to sort of mull over after this deep dive. Considering everything we've discussed, the specificity of the 6th edition, the nuances of OWCP rules like no apportionment, the potential for indirect ratings like Lisa's leg, just how many federal employees out there might be missing out on schedule award benefits they rightfully deserve, simply because the medical professionals involved in their care, perhaps their treating physician or even an initial IME doctor, just weren't fluent in the very specific language and rules of the OWCP schedule award process. How much compensation is potentially being left unclaimed?
That's a powerful question.